Hello, and welcome to another podcast. Today, we're going to look at burns management. Now, burns is something that often gets discussed in trauma management a hell of a lot. It's one of those things that is quite difficult and has a huge amount of considerations that tend to get conflated in different areas of management. So, the spectrum of management associated with burns is one that transcends right from the point of injury, right well into recovery, and even links in with things like mental health and specialist care, like nutritionists and things like that, as it continues on. So it's a real spectral sort of disorder. So because of this, there tends to be a lot of papers and a lot of information about burns management in general that can make it quite difficult to separate the importance and what we need to look at. It's also been something that has been researched for a long period of time. There's even evidence of papers, if you will, that date back over 5,000 years from wars about how to best manage burns. So it has been a hot topic for a long period of time. Today we're going to look at burns in quite significant detail. We're going to look at the pathophysiology and some of the considerations that need to be taken into account with burns. And then we're going to talk about our assessment and the approach, right from first aid, point of injury management, leading into our Role 2E or definitive care or even prolonged management of these particular patients. So to start off, as we always do, we'll just have a bit of a discussion about the introduction. So burns, as I've alluded to, is a significant medical problem that ascends right across all areas of care. Now, 90% of all burns that occur come from thermal injuries. So today we'll focus mostly on thermal injuries, and I'll introduce the other 10%, mostly as an introductory type. Now, worldwide, it's hard to get the numbers, but looking at a whole bunch of papers, it's easy to see that around 100,000 plus burns occur each year, and these are the burns that require medical attention. So I'm not talking about the ones you get at home when you're cooking. These are the ones that actually need medical attention. Now, most of these burns are less than the 20% mark. Obviously, the 20% mark is the one usually associated with more advanced resuscitative management needed. So most of the burns that come into the medical facilities is less than that 20%. And of all the burns out there, the mortality rate sits at about 1.5% of all the burns. So it's not a high mortality rate, really, when you consider how horrific burns can be. Now, obviously, certain variables increase the mortality rate if you were to look at burns at a closer spectrum. So burns that affect people over the age of 65 have a high mortality rate. Burns greater than 40% have a much higher mortality rate. And the general rule of thumb that has been accepted across industry is if you plus the age with the percentage of burn, and that number is greater than 100, that tends to lead to an increased mortality rate as well. Okay. Now, when we look at combat-related injuries, it's again difficult to get an exact number across the different sorts of combat zones, but it is around 5 to 20% of all combat-related injury is associated with burns. Now, in those situations as well, 80% of them are less than the 20% total body surface area as well. So when we start looking at the numbers that need advanced resuscitation when associated with burns, the numbers are quite small. It doesn't reduce the importance of proper management with this particular number. What it does is mean that we shouldn't ignore the smaller numbers because they need proper management, and sometimes long-term management, even though they may be small in surface area, doesn't necessarily mean they're not significant for other reasons. They just have a very, very low mortality rate. Okay, so we will still focus on the over 20% management, but just know that statistically speaking, you're more likely to see the under 20% burns. Now, for anyone that has seen a less than 20% burn, but over 10% burn, that is still a significant burn. And a lot of industries will consider that a reasonable reason to call specialists within a burns unit for management, anything over 10%. The 20% rule is purely for resuscitation that mostly leads to fluid resuscitation early. And when we look at burns associated with trauma, we get a number around 5 to 7% of all the burns that we mention have associated trauma. And that can make it difficult when we look at management principles, especially associated with crystalloids. Now, in the event we shift our focus and we think about those large events that have resulted in a larger number of people in history that have had significant burns. So obviously, the Bali bombing comes to mind, a horrific event that was close to home in Australia and ended up filling every one of our burn specialist units with patients with over 70% burns overnight. So a massive, massive event. Realistically, even though the numbers were relatively small as far as events go, it was still enough to completely fill our entire burns capability within Australia. And these similar numbers occur when you're looking at the UK. So in the last 30 years, for example, there's been 3 incidences within the UK that has more than 5 patients. So 2017, like Grenfell Tower burn, it highlighted a lot of information about how to manage such a disaster, even though the numbers were quite small. And that too tend to exhaust the specialist facilities within the area. So it doesn't take much for a large-scale burn event to really stretch the emergency responders and then stretch the resuscitation departments and the specialist burns units within a country. Okay, because burn management for high-end burns and large incidents requires a lot of very, very specific management. Because of things like this and burns complexity, there has been a lot of research into the best management. And in my opinion, the Brits are doing one of the best jobs in the world of researching burns and coming up with recommendations. And because of these recommendations that have trickled down to other departments, there has been a significant reduction in mortalities as technologies and managements improve. Okay, so that's a good thing. But what that does lead to, it means that there's an increase in long-term management of burns victims. Okay, so they may survive more likely these days, but that doesn't diminish the amount of care that these patients tend to need long-term and sometimes lifelong care as well. Moving away from the introduction to burns, we'll have a look at the physiology. Now, Jackson's paper a fair while ago now came up with certain zones to describe tissue and certain zones that we need to focus on when dealing with resuscitation. And it's been pretty closely linked to management principles and also what tends to happen if you have poor management versus good management. So when you have a burns injury, it causes a coagulative necrosis across various layers of the skin and the underlying tissue. Now, because it's the main function of the skin is to be that physiological barrier, you tend to protect the underlying tissue below the skin, which can be a good thing. The skin usually limits that spread, okay, unless you get into something known as a 4th degree burn, which we'll have a look at. You tend to never actually influence the muscles or the bones or anything underneath. Okay? It tends to be contained within the skin. Now, the extent of the damage that occurs is obviously determined by the temperature, the energy transmitted by the causative agent, and the duration of the exposure. Now, in principle, the sites of the cutaneous burns can be divided, not easily, but can be divided into 3 zones. So the first zone is the zone of coagulation. Now, this represents the area of necrosis with irreversible tissue damage, and it generally occurs at the time of injury. As we move out from the coagulation zone, we move into the zone of stasis. Now, the zone surrounding the coagulation zone is moderately damaged with vascular transudate and elevated vasoconstricting factors. So it sort of acts like hemostasis in this particular zone. It has local inflammatory reactions resulting in impaired tissue perfusion. Now, depending on the wound environment, this zone may recover or progress into necrosis. And what tends to happen in research that looks at poor management, poor resuscitation of burns versus good resuscitation of burns, is the coagulation zone will tend to spread to the hyperemia zone in poor management, and in good management, the stasis will tend to hold it at bay and keep the coagulation zone the same size throughout the resuscitation. Okay, so that's the goal of resuscitation, is obviously to reduce the amount of necrosis. Okay, so that area there is under pretty strong vasoconstriction, which means it's working anaerobically, which means it doesn't have a good survival rate without the support of good resuscitation. As we move further out from the burn, we have the zone of hyperemia. Now, this particular area is filled with dilated vessels caused by a huge amount of inflammatory mediators. It is characterized by increased blood flow to the healthy tissue. Okay, there's very rarely necrosis in there unless you move into prolonged hypoperfusion or sepsis. So this is the zone that is used to support the zone of stasis. The hyperemia zone goes through vasodilation in order to get an increase in blood flow to the area, in order to get an increase in white blood cells to clean up all the mess and support the area of stasis. Unfortunately, what tends to happen is you tend to get an overabundance of fluid that will look out next, which can obviously lead to more concentration. So it's a very big balancing act of supporting the hyperemia zone with proper management, so perfect perfusion management, in order to keep the stasis area as healthy as possible to minimize the zone of coagulation from spreading. That is the goal of managing a burn. And whilst we do that and we manage the burn with those sort of principles, in turn we look at managing the overall body, which we'll look at next. So part of the overall danger associated with burns is a concept known as burn shock. Now, whilst it isn't an official label of shock, it's been characterized in literature to describe what happens in burns that are greater than 20%, and it articulates a mixture between hypovolemic and cardiogenic shock. So just to break down how that works, because it will link into our fluid resuscitation management, is when you get a burn that's greater than 20%. Okay, now anything less than 20%, we still get the same inflammatory markers, we still get the same local reaction, but it doesn't seem to be large enough to cause a systemic response. Okay, so 20% seems to be the magic number when we're talking about this. So locally, we get an increase of those local inflammatory markers, and that's denoted by that zone of hyperemia. So we're talking histamines, prostaglandins, and your bradykines. They all form and they cause vasodilation. On top of that, the area that is actually burnt has direct vascular damage. Now, when you get direct vascular damage, what that means is the actual endothelial lining of the vascular walls tend to break as well. And remember all the talk we've had about the endothelial lining, that leads to an increase in other mediators being released, so very special mediators outside of those localized ones, and it causes that inflammatory response. Now, part of that inflammatory response obviously increases the vessel's permeability. As you go through vasodilation, all the capillary beds are completely opened up, which means as fluid infiltrates into that area at higher pressure, it tends to leak out. So the hydrostatic pressure increases because of the vasodilation, and it will leak out. And this obviously causes a shift in plasma. And because of the openness of the area and the pressure, we also get a shift of proteins like albumin into the actual interstitial space. Now this occurs locally, and then when it's over 20% burns, it also occurs systemically. So it's generally associated around the burns, but as time goes on, we can actually find systemic vessel permeability, which means we'll have plasma loss throughout the body. So the increased hydrostatic pressure caused by the inflammatory mediators opening up all the capillary beds increases the hydrostatic pressure, which pushes out the plasma and the proteins, and that protein now sitting within that interstitial space causes an increased osmotic draw, which means that what is supposed to happen is the osmotic draw found within the vessels is supposed to bring the fluid back in. It doesn't happen anymore because we've shifted the paradigm. So now the osmotic draw is on the other side of the vessels and we end up with oedema. Generally associated in burnt areas, but can occur in the unburned areas as well. Now, obviously, as a result of that, we can have associated problems with airway, neck swelling, facial swelling, can have greater effects on the other areas of the body, which just compounds the issues further. Now, as this fluid shifts out of the intravascular space, we get an overall reduction in intravascular plasma, obviously, and that means that we have a decreased circulating blood flow. This decrease in circulating blood flow obviously can lead to our hypovolemic shock, but at the same time we start to get a link with the cardiogenic side as well. Decrease in intravascular plasma means a decrease in the blood volume that goes back to the heart, which means a reduction in preload. Now, because of the decrease in the receptors that are used to measure actual blood pressure within the body tries to compensate with systemic vasoconstrictive mediators. But now these are in direct contrast to the already existing systemic vasodilators and inflammatory mediators that are occurring. But the body will still obviously try in order to increase and maintain that blood pressure at least a little bit to support perfusion. Okay, now depending on where the body's at as far as compensation, this systemic vasoconstriction can support the body for a while, but as with general hypovolemic shock, this compensatory mechanism can only kick in for so long. Okay, so that will result in an overall reduction in stroke volume, which is leading to the cardiogenic shock as well. And to make matters worse, whilst all those inflammatory mediators we spoke about before that were causing the systemic vasodilation, causing the vessel permeability, also releases a huge amount of free radicals. And these free radicals will interfere with the actual myocardium. And this puts the heart under stress, means it's far more likely for arrhythmias to occur, and it also reduces the amount of contractility that occurs within the heart. Now, this is mostly due to the sodium shifting, and there's a few theories out there of what is actually the leading cause of it. One side of the fence suggesting that it's due to an overall reduction in adenosine triphosphate being available and therefore reducing the contractility of the heart, whereas others will argue that it's got to do with the increased membrane permeability to sodium ions associated with the increase of the sodium-potassium pump activity. But either way, what is known is the contractility of the heart reduces in burns because of the increase in inflammatory mediators and circulating free radicals. Now, this decrease in contractility compounds that reduction in stroke volume, which leads to cardiogenic shock as well. So we have this mix of hypovolemic shock and cardiogenic shock that fuse and form this wonderful burns shock. So if you've ever wondered why fluid resuscitation and why fluids are lost in burns, this graphic pretty much demonstrates the overall picture of what we're talking about, of how we get a very special type of shock called burn shock, which is a result or a complication, if you will, of burns that are over 20% causing what has been coined end organ hyperperfusion. And when we get or have a situation where we're encouraging end organ hyperperfusion, it results in organ dysfunction and we get this hypovolemic versus cardiogenic shock. Now, having said that, I think it's a particularly important point to note now that whilst we've established that hypoperfusion is dangerous, we also need to mention, and we will mention again, that over or hyperperfusion excessive amount of fluid can lead to worsening the edema formation, and it can also lead to elevation in compartment pressures, acute respiratory distress syndrome, as well multiple organ dysfunction. Okay, so over-resuscitation has been proven to have a detrimental effect on mortality and morbidity, even to the point that even a little bit of fluid creep can profound airway edema and cause something known as abdominal compartment syndrome as well. So just to make matters that little bit worse is we can't just fill these people up in order to maintain an average blood pressure. Okay, it doesn't work that way at all, and it needs to be a perfect balance for the body. It's very unique with very unique burns. That means that you are not hypoperfusing the organs, and you're also not hyperperfusing the organs or increasing fluid throughout the body. Now, in order to assist us in obtaining this utopian level of resuscitation for our patients, there's a few variables and classifications that we need to understand and really need to understand well when we discuss principles of management. And the first one we need to talk about is the classification of burns. Now, most people that you'll speak to are quite comfortable with the concept of first, second, and third degree burns. As you move on in your clinical career, you'll have other classifications that will come in through superficial, partial full thickness, okay, and even fourth degree burns coming in. But the bottom line is when we're dealing with resuscitations, we really worry about those second degree burns into those third degree burns. If we get a fourth degree burn, then we're worried about infection. Okay, big infection because it's involving the muscles and the bones. Okay, and it often leads to amputation of that area. Okay, third degree burns are not painful by definition, okay, but there is a huge risk of infection. When we're looking at the need for fluid resuscitation and the highest risk burns associated with losing fluid, we're looking at those partial or second degree burns. So it's these particular burns that need to be classified when we're looking at our fluid resuscitation. Now, in order to make it a little bit easier for us to calculate surface areas, a lot of guidelines will say that any second or third degree burns count towards the total body surface area, but first degree burns don't. Now, this sounds relatively easy in theory, but is one of the leading reasons behind the miscalculation of total body surface area that is burnt. Okay, it's not the only variable, and we'll discuss a few more, but it is the leading one. Because when you're on the ground and you have a burn and it's mixed in with clothes, and the second degree burn is blending with the first degree, and you have an area of third degree, you really won't know on the ground. And it's also not appropriate on the ground when you're doing first management to scrutinize the difference between it, doing the pain sensation or any other sensation test associated with the areas to see if they've lost nerve feelings, see if it involves the dermis or just the epidermis. There's really no good way to tell. You add other injuries to the mix, you add clothes burnt onto the mix, and it can be extremely difficult to classify what is a first, what is a second, or a third. So bottom line is we do our best and we have a look at a burn, and if we believe it constitutes over 20% burn of second and third degree levels, then we start our fluid resuscitation. Now, just to put that in perspective, when we start talking about rule of nines and all those things, which we will next, we're talking about someone with an entire leg burnt plus their two palms. Okay, just as an indication, okay, that is 20%. So most of the burns that we see throughout our career are going to be less than the 20%. Doesn't mean they don't get good management, it just doesn't mean the complications of fluid resuscitations needs to come into it. Okay, so that's the first classification that we'll look at. The next one that they get us to do is obviously we look at how much percentage of the body has been burnt, which just adds more levels of complexity to the problem. So if we remember, the first level of complexity is quantifying second versus first versus third degree burns is difficult enough. Now we need to bring in the rule of nines in order to ascertain whether or not it meets that 20% threshold. So the general rule of nines was created in the 1950s. As a typical story, it was created by some individuals, and then it was written in a paper by a guy with the last name Wallace. So it's often coined the Wallace Rules of Nine. Okay, so in 1951, Wallace, as part of the National Burns Research Council, put in this rule of nines. Okay, and it was a rule of nines associated with adults at the time. And in the 1950s, adults were generally a similar size. And if they weren't, a lot of papers didn't actually care too much about variables of human sizes. So as time progressed on, it included things like young children and infants to make it that little bit more complicated. But it also had quite significant scrutiny in the 1980s and thereafter. So what it was found is the original rule of nines that you will find, so the general one that is often thrown around there, is relatively accurate for patients that are between 10 and 80 kilos. Okay, so that's pretty much it, and that's relatively accurate. Okay, now it does not take into account any of the dysmorphia or any variation in weight, height, or body shape. And in particular, it doesn't really constitute a variable of BMIs. So when you have BMIs that are over 30, which is not really that hard to do. For an example, in the US, when these things were made, the rate of obesity, so people with a BMI over 30, went from twofold in the 1980s to sevenfold in the 2020s. Okay, so that's how many people now are classified as obese, BMI over 30. So when you have patients with a BMI over 30, you'll quite often have up to 50% of the total body surface area found within the trunk, as opposed to the traditional 36%. Okay, and as a total surface goes, the legs can constitute as low as 7% and the arms 6% for that matter. Now when we add other variables in there like children and different shapes or genetic dysmorphia, it obviously adds layers and layers and layers of complexity. Okay, let alone the complexity associated with different size humans or different age humans as well. So to combat this, a few organizations have come up with other rules. You've got the rules of fives, you've got the palm rule, which again has variables associated with men versus women and the ratio of what 1% is for the amount of population. Most of the time, men's constitutes 0.8% per palm and females is 0.7% of total body surface area per palm. Ludds and Barbaro came out with a graph that when you do have that perfect patient, is a more accurate way of obtaining a percentage of body surface area, but even that has layers of variability associated with age. So the reason I'm bringing this out, the reason I'm saying how many variables are associated with it, is maybe to encourage that the rule of nines and the point of injury management of burns doesn't have to be exact. And we have many papers that suggest that as you go through levels of care, the variables associated with estimated body surface areas changes dramatically. And unfortunately, what has happened in literature and over time is point of injury carers will tend to over classify the body surface area, but then under resuscitate, okay, which is probably the worst combination because you think you have more surface area burnt than you actually do at second and third degree, but still statistically are involved in under resuscitating to that number. So when we're looking at burns, We just need to ascertain whether they fit into certain categories. Okay, and certain burns organisations have come up with certain categories. So you do your best, you use the rule of nines or the Ludsborough or something to ascertain second or third degree. You do it quickly, and you just need to know if someone fits in that less than 20%, that 20 to 50%, or that greater than 50% range. Greater than 50% range has a huge mortality rate and needs quite aggressive resuscitation and evacuation. 20 to 50% still is significantly bad, okay, but the management can tend to start earlier in the pre-hospital and continue to lower areas before moving on. And less than 20%, as we know, can be held onto for a little bit with some management before we move them on. Okay, so that could be a way that we start classifying percentage of burns. And as we move into management, we'll talk about some principles that maybe we should adopt as opposed to some age-old adages that is supported within our protocols. So let's start by looking at first aid and what is really important associated with first aid. So when someone has a burn, everybody knows the best thing to do is to cool the burn. Okay, that's a no-brainer. You have to cool the burn, you have to stop the burning process, and you do this the best way you can. Now, it has been quoted for many, many, many years that having running water for 20 minutes is the best treatment. Now, there are some evidence out there that suggests that if you have water running on a burn, that all the heat or most of the heat is removed after 10 minutes, and everything thereafter is just associated with helping out with the pain. Okay, so if you only have 10 minutes of running water, then you can get away with doing 10 minutes and then worry about taking care of the person's pain as well. Now, because they've done the studies, they can let you know that the optimal range of temperature that you should use for water is between 10 and 20 degrees. Any cooler, you risk vasoconstriction, reducing blood flow to the area, and obviously increase the risk of hypothermia. Any higher, and it doesn't have that thermoregulation difference in order to be effective. Now, in the event you're short of water, like every single time you're in the field, you can use wet pads or towels and then obviously placed on the burn, but those towels or pads need to be recycled every 15 seconds. So if you have two towels, you place one towel on as you wet the other one, and then you take that towel off, re-wet it, place a new one on, and you keep swapping this. This is a great job for non-clinicians whilst you get involved with a lot of other things that needs to be done. Okay, but it is a good trick and it is effective, but you have to make sure that they're rotated. If you don't rotate them, you just create a nice little oven of heat distribution and the burning process just continues. It doesn't do anything at all, okay? Jewelry, watches, necklaces, all those sorts of things should be removed as early as possible. And Glad Wrap is your friend. Once the cooling has been done for that 10 to 20 minutes, you can put Glad Wrap over it, which is a very effective pain relief because it creates a barrier like the skin that protects the nerve endings. So we place the Glad Wraps over the top, underneath, and we pretty much build layers around, still connecting, so they're still secure. We just don't wrap the body limb up because of the potential for edema later on, especially as we start fluid resuscitation. So that's what we teach our first aiders and CFAs. So then by the time it comes to us and we start resuscitation, we can actually do it effectively without the risk of compartment syndrome and things like that. We also get them to prevent hypothermia. There's not a lot of literature out there that says the cooling of burns causes directly hypothermia, but obviously it doesn't help. Dumping cold water on someone in a cold environment with the compounding issue of hypovolemic shock and the lack of skin to prevent heat loss is obviously a recipe for losing a lot of heat. So we get them to prevent hypothermia, which is why we encourage the cooling of burns for 20 minutes, unless it's been over 3 hours, and then you don't even bother. And once that cooling has been done, we don't therefore continue to cool at every stage of care. So we don't cool at point of injury and then recool in the resus bay and then recool in the hospital, because that just compounds the hypothermia. Once you move away from the first aid management, you start looking at the integ side of the house, and we start looking at some more advanced stuff. Okay, so when it's got to do with airway, we need to ascertain two variables associated with that. So in the event, we identify that the person has some sort of inhalation injury. Okay, this is done right at the start. We can define that airway burn as a supraglottic or an infraglottic airway burn. So majority of all the burns will be a supraglottic, okay, which means it's limited to the naso-oropharyngeal down to the larynx. Now this is because of the hugely effective capability of heat exchange in the upper airway. If you imagine breathing in cold air, by the time it gets to our body, it's nice and warm. That same heat exchange ability tends to protect the lower areas most of the time. So heat damage to the supraglottic airway may be severe enough to cause airway obstruction. Okay, now this generally happens either later in the piece or when you start fluid therapy. Now you obviously need to start fluid therapy for bad burns, but sometimes as a result of starting that fluid therapy, we increase the probability of edema. Okay, so we need to think about definitive airways early when we're dealing with inhalation burns, particularly for infraglottic airway burns. Now they're considered when the mechanism involves steam inhalation, aspiration of scalding liquids, a blast injury, an injury associated with flammable gases released under pressure, and obviously any aerosolized chemicals. Another indication that you can find when you're dealing with an infraglottic airway burns includes impaired ciliary activity, redness within the mouth, hypersecretions, starting of edema, ulcerations, or bronchial spasms, like lots of coughs and things like that. When we get into this situation, supra or infraglottic, we need to make a decision of whether or not the person needs a simple airway, whether it's a naso, or maneuveral with oxygen masks on, or if we need to move to more of a definitive choice. There are choices on the ground that a surgical crike can be considered to prevent the airway, particularly when we're dealing with infraglottic injuries and evacuation times to higher facilities are reduced. Okay, so it can be a consideration that needs to occur early. When we're dealing with the breathing side of the house, we generally work with the same rule of thumb associated with oxygen therapy. So we have the greater than 94% rule when we're dealing with general burns. Now, if you have a burn that involves the airway, the neck, anything like that, it is best to place oxygen on early because our simple probes, pulse oximetries, can't tell the difference between oxyhemoglobin and carboxyhemoglobin. So it may read a high percentage, but if there's anything associated with smoke inhalation or airway burns, things like that, then it can mean that the oxygen numbers are weird. Now, this is the same phenomenon that occurs with cyanide poisoning. Now, cyanide poisoning is not only associated with warfare. When a person is exposed to fires, usually industrial fires, and they're breathing in a lot of smoke, if there's anything associated with the combustion of materials containing nitrogen, and that is your plastics, your vinyl, silk, your wool, even certain cottons can also release a hydrogen cyanide gas, which means the inhalation of cyanide has the same consideration with messing up the pulse oximetry. So easy rule of thumb, any burn associated with the airway or the neck or involved with smoke inhalation should have oxygen applied early. And if you have the ability and if your tempus can read the difference, it's an added extra between carboxyhemoglobin and oxygen, then you can obviously use that. Moving down to circulation, we must as a minimum get IV access. And if we can't get IV access, we must get IO access. Now you can put a cannula through a burnt area, you can put an IO through a burnt area. Securing it can be difficult because of the moisture associated with second degree burns. So use of bandages to secure it in place is a good idea, which involves obviously covering the burn completely, but access must be obtained. Analgesia, they're going to need a lot. Cloud wrap goes only so far. So the use of fentanyl, 25 mics or even ketamine is a great choice associated with keeping people calm and keeping people out of pain when they're in burns. Okay, their metabolic rate is already greatly increased. We don't want to increase it further by leaving them in pain. We want to continue the hypothermia management, and we want to protect them from the elements, which involves exposing them to have a look at the surface area of what's burnt, but then covering them back up. You don't need to leave the burns open. You can simply put the Glad wrap on, cover them with something warm in order to maintain the temperature. Now, from that initial management, depending how long we hold on to the person, we need to consider other things the more we go on, or as we move into treatment teams or resuscitation bays, depending where it is and depending what your line of evacuation is as well. What we need to do early is we need to consider our fluid resuscitation rate. Now, the fluid resuscitation rate is often coined that we use the Parkland's formula. Now, I understand that we've moved to the rules of tens, generally in the pre-hospital space, but it is still considered Parkland's formula is the most used fluid therapy formula used for burns greater than 20%. Now, it was invented in 1968. So all the way back then is when it was invented. Since then, from the year 2000, it has been proven very often that it results in over-resuscitation of fluids, to the point that a whole bunch of protocols out there will still say use the Parkland's formula, but then base your fluid resuscitation on urine output. Okay, so that's the same way, even our PCCM says the exact same thing. So we start with the Parkland's formula, and then we break it down and we go off urinary output, which obviously means we need to put an IDC in, and we obviously need to measure the urinary output every hour. Now, the golden number is 0.5 mils to 1 mil per kilogram per hour. So that is the urinary output rate that we go for. Okay, so we need to have a general idea of how much the person weighs, and we need to be able to measure it every hour. So we start fluid resuscitation, wait an hour, measure the urinary output. If we have less than 0.5 mils per hour, then we increase whatever that number is that we started with, the hourly rate, by 33%. So 1/3 increase. Now, there's certain protocols out there that says 20%, PCCM says 1/3. So 1/3 it is. If we do the measurement and it's over that 1 mil per kilo per hour, then we decrease the fluid resuscitation rate by 1/3. So for simplicity reasons, if we're giving 300 mils of fluid per hour, because that's what the Parkland's formula has given us, okay, even though we don't figure out an hourly rate, we figure out an 8-hourly rate, but we'll get to that. If our urinary output comes back at under 0.5 mils, then we increase our fluid rate from 300 to 400. If our urinary output is greater than 1 mil per kilo per hour, then we decrease 1/3. So we go from 300 to 200. And then we wait and we do another measurement. We don't do intermediate measurements. We measure it every hour and we base our new hourly number off that particular urinary output. Not previous ones, not future ones. That particular one is what you do. So this is the best practice, is what we do. And this is how we manage not hypoperfusing someone and not hyperperfusing someone, is based on urinary output, which coins the question, why are we using a 24-hour volume fluid resuscitation rates like the Parkland's formula? Okay, there's so much mass out there that people have told you to, times it by 1/8 in order to get the hourly rate, and then you can start from there. But with all the variables we spoke about before of the difficulties ascertaining what your percentage of burns are, and the difficulties ascertaining what severity of burns you have, and then figuring out a Parkland's formula, 3 mils times that times kilos divided by 50% over 8 hours, then divided by 8 to get an hourly rate. It's a huge amount of mass to do on the ground in a treatment team when we have a patient that needs care. So, because the rule of tens have come in, that can be a wonderful place to start. So you start with the rule of tens, which is a rounding up, really best guess clinical judgment on fluid resuscitation rate, and then we adjust. We can adjust based on deeper examination later on with percentages, or we can adjust based on urinary output by increasing by 1/3 or decreasing by 1/3 the longer our resuscitation goes on. That's what's recommended in best practice. To make it easier for ourselves on the ground, it may be a lot easier to start with the rule of 10 and then resuscitate based on the patient's outcomes, as opposed to trying to do complex maths that has pretty much been ruled out with best practice of measuring urinary output as well. Because after that first hour that you get from the Parkland's formula, the second you change it, it is no longer relevant within the Parkland's formula anymore. Continuing on with our management principles, we'll discuss what we do as far as care goes the longer we go on. So the longer we go on with the patient, the more likely they are to get airway complications, particularly when we start fluid resuscitation or as time progresses when oedema kicks in. So typically speaking, oedema can kick in after the first hour and then after the 24-hour mark as well. Okay, so we're hopefully not going to hold on to them for that long, but the only thing that really protects the airway in a burn is a cric or an ET. So this is where the decision has to be made whether or not we're going to go down the route of RSI if we're in a team that can do it, or we're going to go the surgical cric route in order to protect that airway. So this is particularly important: airway, inhalation, chest, and respiratory burns. This also can be a consideration if we are unable to maintain SpO2 levels above 90, regardless of airway intervention, airway positioning, oxygen use, all these sorts of things. If we can't get it over 90 with all of our resuscitation, then generally it could mean that there is an actual ventilation problem that we need to take over. And we often will need to bypass the oropharynx area in order to increase ventilation to get those better numbers and therefore better perfusion statuses for our patients. Breathing, we move in, we continue the oxygen therapy as best we can. If we have associated risks of smoke inhalation, then it might be worth considering the cyanide poisoning antidote, hydroxycarbonamine, 5 milligrams. Carrying that in the recess bay can be a good thing to give to burns patients with suspected smoke inhalation, displaying an altered mental status and especially a cardiovascular instability. Now, it may be due to what we discussed before when we're dealing with hypovolemic and cardiogenic shock. Okay, but when you're associated with smoke inhalation, especially those industrial fires or even vehicle fires, it's a good consideration if you're carrying it. Now, in the event you find someone with carbon dioxide poisoning, oxygen therapy can greatly reduce the amount of time it takes to disassociate the carboxyhemoglobin. So the half-life of carboxyhemoglobin is 320 minutes when you're breathing room air. If we add oxygen on the mix, and especially 100% oxygen, we can reduce that time down to 80 minutes, which is obviously a big advantage. So oxygen therapy for these people is fantastic. Once we get into the treatment team, we need to continue with fluid resuscitation. It's an absolute must. Now, in the event the point of injury person only had normal saline on them, so they use that, we're best to change the Hartmann's as soon as we can, because that reduces the complications down the line. Okay, greatly reduces the complications as the patient continues in their care. Hartmann's is the fluid of choice when we're dealing with burns. Other things that we need to consider in the extended care space is the consideration and the prevention of sepsis. So whether or not we start prophylactic antibiotics, depending on the wounds, or we start cleaning the burns and dressing them a little bit nicer using normal saline, things like that can be a strong consideration that needs to occur in this area. Hypothermia prevention is an ongoing consideration. Okay, now if we have the ability to increase the temperature within a room in order to stabilize them, it is a wonderful choice, and it's actually been proven to reduce this state of hypermetabolism that occurs within burns simply by supporting the environment. Okay, now long goal management of burns is purely centered around reducing the overall hypermetabolism state of a burns victim. So if we can start that process by supporting the patient and preventing hypothermia, then obviously it's a great start. There's not a single treatment team in the Defence Force that is really capable of holding on to a burns patient long term. So their evacuation chain does not end there, because we still need to fight for evacuation for patients to get to better areas of care. Okay, well, that goes through the general management of burns. So we'll just finish up quickly and we'll talk about a few pieces of information associated with the special burns. We won't go into a huge amount of detail with these ones, given the length of the lecture already, but just to point out a few areas of consideration associated with the other types of burns. So chemical burns are particularly nasty, and they account for approximately 3% of all the burns. Now, incidents of this type mainly occur in domestic and industrial settings, and the type of injuries involves denaturing of proteins, and the extent of injuries depends on the concentration, amount, duration of contact, and obviously the mechanism of action of the given chemicals. For example, whether it's a oxidizing, corrosive, visceral agent will obviously determine the sort of burns that we get. Whilst the clinical picture is relatively similar for all the groups of chemicals, the exact mechanism of tissue damage may vary. Therefore, the treatment and management of the burns can vary as well. So generally speaking, acid burns resulting in protein denaturing and necrosis, which is usually localized and short-lived. Alkaline burns, on the other hand, cause progressive liquefaction necrosis, with much deeper tissue penetration and prolonged offense. Cement burns is a classic example of alkaline burns, especially when mixed with sweat. Now, washing with copious amounts of water dilutes the chemicals and helps reduce the tissue damage. Burns are most likely caused by acids. When we look at electrical injuries, they account for just less than 5% of all the burns. They are most common in children and male workers that obviously work within the industry. The severity of injury is determined by the voltage and the ampage, the type of current, and obviously the duration of contact, and then exacerbated by the pathway in which the current can pass through the body. Most tissue are good conductors, especially nerves and vessels. Skin and bone, on the other hand, are poor conductors, which obviously works in our favours. Now, skin's conductivity can vary depending on the amount of moisture they have in contact and the temperature of the skin as well. The heat is generated by electricity around the tissue and damages the local surrounding tissue. Clinically, you often observe the so-called entrance and exit points where the electrical current has passed through the body. An electrical voltage less than 1000 volt, typically found indoors, causes a small but deep burn and has an entry and exit point. Alternate currents can also interfere with heart function and lead to arrhythmias. When we're dealing with high voltages, which is classified as greater than 1000 volts, that leads to extensive tissue damage, often with loss of limbs, asystole, cardiac arrhythmias, and then, if they survive, rhabdomyolysis, renal failure, things like that. So very, very bad burns, difficult to resuscitate. The fluid resuscitation in these particular cases is incredibly complex in nature because of the associated urinary output differences and the need to protect the kidney with the associated rhabdomyolysis whilst trying to prevent overperfusion injuries of the burns. This type of injury is associated with an incredibly high mortality rate, which approximately 15% of all the victims associated with these types of burns, electrical burns, will also have associated injuries from a fall as well. And the final type of burns is obviously our radiation burns. Now, generally, harmful radiation is caused by alpha, beta, and gamma rays. Alpha particles are positively charged helium ions usually. They're heavy and can only travel through centimeters in the air. They cannot penetrate the layers of the skin. However, they're high energy particles with high servants can cause extensive tissue damage upon ingestion and inhalation. So you're completely protected from alpha radiation on your skin, but if you ingest it or breathe it in, it can be particularly nasty. Now, beta particles are negatively charged electrons, beams that can travel through several meters in the air and cause significant sunburn-like injuries because of the limited ability to penetrate into deep tissue, generally associated with 1 centimeter. When we start looking at gamma radiation from X-ray, the natural decay of the radioisotope, such as your cobalt, can travel several meters in the air and penetrate into deep tissue. Consequently, gamma rays can cause very deep damage involving vital structures such as bone marrow, lungs, and can even bypass the layers of the skin. And deep gamma burns on the skin can experience systemic problems, usually associated with deeper problems like your acute radiation syndrome. Okay, so that brings us to the end of burns management. As you can see, a lot to think about. Bottom line is obviously we have protocols for a reason. Now, some of these protocols are written for our environments. Some of these protocols are not. At no stage are we directly to go against our protocols without permission from medical officers in certain circumstances. Okay, but when we are met with a protocol that has information in it that could potentially be achieved through quicker means or more contemporary means associated with our environments, it is definitely something that needs to be reflected on, especially if potentially that management can result in better initial management of patients to fight against the statistics that have been described to us as general poor management within the pre-hospital space, which in turn will help our patients through the chain of care and reducing the complications that might occur from burns. But until next time, take care.